Who is presenting? Nicole, you're presenting the poster? All right, let's get going for today. Reminder that there is no live stream after this today. Instead, tonight, 8 p.m. Eastern time, so wherever you guys are at, we'll start Steps Trivia Night. We're going to use the platform Kahoot. It was the easiest to allow everyone to join. And one thing with that, you'll need to have someone, if you're playing in a group or you're playing by yourself, someone has to use their phone essentially as a buzzer. And then you'll have to have a computer screen up to be logged into Zoom. So have the computer screen up, log into the Zoom, and we'll put up the questions that way. And then you'll use someone's phone as the buzzer. So that'll start at 8 p.m. We'll kind of leave the Kahoot waiting room open for maybe about 5 minutes or so for everyone to get on there and join. And then maybe we'll start trivia around 8:05, 8:10. So just a reminder for that. So today we're going to chat a little bit about ankle fractures for the next hour. So let's sort of jump right into it. Do we have a volunteer to take the first case? I see Carol Baskin's out there somewhere. Any volunteer to take case one? This is as an extern, as a resident, the kind of stuff you're going to walk into in the ED.
I can do it.
All right. So here's your case. It's almost 2 o'clock in the morning. You've got this 49-year-old guy that walks into the emergency department, or I should say does not walk in, is carried into the emergency department. And, you know, his partner's with him. He says, hey, he got really drunk at a party a couple of hours ago, down a flight of stairs. He can't put any weight on the foot at all. He's had quite a bit to drink tonight. Your step one.
All right, maybe I don't want to take the case, but whatever. All right, let's go.
What's that?
No, maybe I don't want to take the case.
Okay.
I'm kidding.
Now you're committed.
All right, yeah.
Called you. So the ED doctor called and said what I said to you just now and what's up on the screen, and says, hey, can you please come in and see this guy? Anything you want me to do now?
Stabilize, check circulation.
He says, well, I'm not a podiatrist, you are, so you do that. What else could he be doing though while you're driving in?
Put an EKG up, check airway, breathing, circulation.
Okay. So he's medically stable.
Okay.
What else? What are you gonna want as soon as you get there? Yeah, people are.
Yeah, I mean.
Comments. X-rays, right? Yeah. Yep. So something that when you're on your way in, ED doc calls you. When you know you're the first year intern resident, you can tell them exactly what views you want to get, so that they can have that done by the time that you get there. A lot of times that's already done without even asking, but making sure that that's done when you're on your way in can be really helpful. So what are you going to tell them? What views do you want?
AP, that
broke up a little bit. AP lat.
Yeah, T's more T2.
Okay. So you get in there. He's going to take the x-rays for you. And then that's what he looks like once you're in the emergency department. So he's not doing too bad pain-wise. He's had plenty to drink, so he's a happy camper. But you take a peek, and your initial impression of looking at that is, my concern is what?
Like dislocated ankle compartment syndrome.
Okay, so clearly dislocated, right? People are throwing some things out in the comments there as well. So you look over at that medial side. Significant dislocation. So I see somebody wrote open fracture, potentially, but let me give you all the views there.
Maybe,
so nothing open. But that medial side, what's over there on that medial side that's of concern? Yeah.
The neurovascular bundle.
Yeah. So we've got a heck of a lot of pressure on that medial side, right? So what's our concern now? It's 2 o'clock in the morning. The guy's drunk. He's obviously been eating and drinking. We're not going to take him necessarily right away, or maybe we are. But what do we need to do? So somebody said compartment syndrome. We can check for compartment syndrome. He does not currently have any signs of compartment syndrome. They're giving it to you here in the comments. So we want to close reduce that, right? So we see that ankle that's laying there in the ED bed that looks like that, and our immediate thought is get that pressure off that medial side as quick as possible. So that's closed reduction, and Aaron already answered my next question as far as your process to go about close reducing that ankle. So increasing the deformity, distracting, and then reducing. Out of those three, which one do you think you're going to spend the most time on? So out of that process of closed reduction, increase the deformity, distract, and then reduce. So you're going to spend the most time distracting. So it doesn't take too awful long to increase the deformity, and it shouldn't take too long to reduce the deformity. Those are fairly quick, hard motions, but distracting is where you really want to hold that out and spend a little bit more time. So you got your baseline x-rays. Next step is describe those x-rays. Anyone, if you want to pass it off, anybody can take it. Okay, let's start here. Normal or abnormal? It only works if we get volunteers, guys.
Abnormal.
Yes. Let's move on to step.
I had a question in the chat. Is there any consideration of the alcohol for any type of sedation needed for the distraction?
You tell me.
How drunk is he?
Well, so he's drunk enough to have fallen down one flight of stairs. Let's just assume he's had a significant amount of alcohol. So I'll leave significant up to whatever. I'm not going to reveal myself as far as significant alcohol intake here. So if we're talking about closed reduction and we're talking about sedation, you bring up a good question. And we're saying, okay, we're concerned about the amount of sedation or what we would need to give him for closed reduction. What's another option we would have that we can definitely do for this guy in order to be able to perform a closed reduction? Because I'll tell you, he's not feeling much pain, but it would still not be a good idea to close reduce without doing anything for him. So what else could we do if we didn't want to do any sort of conscious sedation?
A local block?
Yeah, what's that called specifically?
You could do the ring block around the ankle.
So different type of block. So a hematoma block. We've heard of that before. So pop block would be a potential option too. If you did a pop, well, I'm not going to ask that because that's part of our trivia question tonight.
Oh.
Never mind. We're going to save that other question for 8 p.m. Okay, so let's say, we either have done a hematoma block, he didn't have enough alcohol, we were able to do some conscious sedation. Let's go back to reading these x-rays. So as far as fractures, someone give me some idea of what's going on here as far as fractures.
I believe someone said PER 4, most likely.
Okay, so before we get there, that's a couple steps ahead of us. Let's back up. Start to ID these fractures.
Okay, there's a fibular fracture that I can see. It looks like a medial mal fracture, as well as a posterior mal fracture.
Okay, so let's get real specific because when you call your attending on the phone, you're going to have to then describe these fractures in a bit more detail. So going back to that fibular fracture at the level of the?
At the level above the ankle joint.
Okay, good. So Janice Weber. Yep, they're helping
C.
me out in the comments. Good. So Janice Weber C, well above the level of the ankle joint. Okay, next you said what fracture?
Medial mal.
Medial mal. Okay, so describe at least a bit about that medial mal fracture.
Let's see here. So from the first
Vertical,
image,
does it look transverse? Does it look like a short oblique? Is it minimally displaced? Is it completely displaced?
it looks transverse. However, it's displaced in relation to the tibia. It's laterally displaced in relation to the tibia.
Okay.
It does look like it's minimally, like as far as like the positioning next to the talus, it doesn't look like it's too far displaced there.
But it is displaced from where it fractured, correct?
Correct.
So we have a complete severe displacement of that medial mal from the point where it fractured off. So one thing to note would be position that that tibia is in relation to where that medial mal fragment is at, right? So that medial mal fragment is now almost under the complete lateral side of the distal tibial plafond there. So remember that little acronym. I know I've mentioned it before that can help you when you're trying to get specific in talking about fracture orientation. That terrible little acronym called LARD, location, angulation, rotation, displacement. If somebody is saying to you, you said, okay, there's a distal fibular fracture, or just there's a fibular fracture, and they say, describe that to me more, just kind of run through that little mnemonic in your head. And that can help you get pretty darn descriptive about these fractures. Okay, third fracture is where? Is there a
Posterior
third
mal.
fracture?
Possibly posterior mal from
Okay.
the first.
Where do you actually see that most apparent, on what view?
The AP.
Yeah, interestingly enough, a little bit less apparent probably on the lateral and more so on the AP. Okay, so if you had to describe this as far as displacement, good. Somebody said Volkmann, so posterior malleolar fracture, also called a Volkmann's fracture. If we're going to talk terminology, what's a tibial avulsion fracture off the AITFL? So if a posterior mal fracture is called a Volkmann's fracture.
Hello, Chaput.
Yep. Tilo chapeau. I don't know how you say that last word exactly. What's an avulsion fracture off the AITFL of the distal fibula? You guys are way ahead of me today. Okay. So Wagstaff fragment. So Wagstaff fragment, sometimes people just call it a Tilo fragment if it's AITFL off the anterior tibia, and then Volkmann fragment or Volkmann's fracture posterior mal. Okay. Let's move along here. So we talked about closed reduction for this situation. Actually, to go back to classification, I know you guys sort of already answered it. You said PER. PER what? So I guess, where does PER start? Start me off from stage 1 of PER. Okay, good. People are saying medial mal or deltoid. And then it moves where? Okay, AITFL. So that's where we can get that to low, or that Wagstaff fragment. And then where? Good, distal fibular fracture. Nobody can speak today, but a lot of people can type.
Everyone's saving their voice for later.
Oh, yeah, I guess so. Okay, and then 4 would be what? Yep, we got it. Posterior mal fracture, syndesmosis. Okay. So PER, how common is it to have syndesmotic disruption? Pretty darn common, or not as common? Very.
Very common.
Absolutely. Very, very common. So always, always, always suspect some degree of syndesmotic disruption in a PER. So this is our closed reduction on this patient. So if we go back to what it was compared to what it is now, somebody comment on that. They get an F, they get a B, they get an A.
Feels like a B, B minus, but it's definitely a great improvement.
So tell me why. Tell me why a B minus and not an A on this closed reduction.
So I don't like how much the fibula is still displaced, and then the tibia is still not aligned well with the medial malfracture, and I can't see the posterior much from here.
Okay, so what do you think is more important than looking at that medial malposition along the distal tibial plafond? Yeah, somebody said it in the comments, the ankle joint, right? So look at the talus. Kind of forget about that medial mal for a second, because that medial mal is going to kind of go with it. So look at the talus in relation to the distal tibia. So where is that sitting? Is it still sitting medial, still sitting lateral? Is it in a bit of valgus? Is it in a bit of varus?
More lateral than it should be.
Yeah, so everybody's commenting on that. So that's what we really want to look at, right? Because that's our whole goal. Our whole goal is to restore anatomic alignment, to get that distal, to get that talus back under that distal tibia. So this didn't completely accomplish that, and I completely agree with you about that fibular fracture as well. So what's your plan for somebody like this? What are your options?
You mean for fixation of the situation, or do you mean our approach to the situation?
Yep, either or. Just give me a stab at it, okay? Somebody doing surgery once soft tissue swelling has gone down. Does it look like he's got a lot of soft tissue swelling at this point?
No.
No.
But I would like to get the fibula at least to length.
Okay.
So I think because it displaces posteriorly, I think a posterior anti-glide plate would be in order.
Okay. So you want to take him in for an ORAF?
Correct, but the problem would be approaching posteriorly on the patient.
The problem, why would that be a problem?
Well, because if you have them prone, and especially if they're alcoholic, it increases complications in surgery, and then you also still need to attack the medial and anterior side. So prone isn't the best position, but you could approach it laterally, but it's much more difficult from what you guys have taught us.
Okay, so yeah, so you sort of already answered what my next question would have been. So does a patient have to be prone, or are they typically prone to fix a fracture pattern like this? And the answer is probably not, right?
Correct.
So they can go into what we call a lateral decube, a lateral decubitus position, and we can still access posterior plating on the distal fibula if we need to from that position. So this guy doesn't necessarily have to go prone. So since I've already taken quite a bit of time on this case, I'm going to move along to the fixation that he ended up having. So somebody describe this fixation for me. So again, let's give it an A, a B, a C, or a D, or an F. Tell me why.
I'm gonna venture B plus.
Okay, we're moving up a little bit. Tell me why. I think one of the important things is being able to look at how something was fixated and see where improvements could have been made.
Correct. So it looks like the fibular fracture looks like it was well reduced, fixated with a plate and screws.
Okay.
They have 2 transsyndesmotic screws, and then 2 screws for the medial mal as well. Looks like they didn't do anything with the posterior malfracture, which is common. The talus still looks like it's kind of laterally deviated.
Good. That's exactly what I wanted you to notice. So that talus is not sitting perfectly, right? It's not exactly where we'd want it. We'd ideally like a little bit better reduction at the level of the ankle joint.
Now, is that something that would be due to the screws, the syndesmotic screws? Like, how would you accomplish that, basically?
Yeah, so what would be one reason that it would still be sitting in that lateralized position? And one reason for that would be inappropriate syndesmotic reduction, right?
Mm-hmm.
So perhaps this was a syndesmosis that wasn't appropriately reduced. So to go look at that lateral side, do we have any intrafragmentary screws on the distal fibula? I'm sorry, I just noticed a question in the comments here from ICRA, what is PER? PER stands for pronation external rotation. And pronation external rotation is one of the Log-Hansen classifications. So any interfrag screws on that distal fibula.
No.
No, right? So that's a plate, and we've utilized 2 syndesmotic screws on the distalmost portion. And if you had to describe those syndesmotic screws, how would you describe those? Yeah, so somebody said worried about those syndesmotic screws not going the whole way through, so AKA they're not quadricortical. Okay. And yes, potentially could be one of the reasons we didn't get as good of a syndesmotic reduction as we wanted to. Yes, fully threaded screws. Are they at the appropriate level above the ankle joint? Oh. Sorry, I'm trying to manage these comments, and so is it too close to the ankle joint, Deanna asked. What should it be at? 3 centimeters is too high.
Sorry, I'm just gonna talk. Can you hear me?
Yep.
Okay. So you're saying
Thank you.
So you're saying 3 centimeters above the ankle joint is too high?
Where would you ideally start your first syndesmotic screw?
So I remember something like that when I was studying this, like the rule of threes. I don't know. I learned it this way, and it's like, I don't know. I thought it was maybe it's 3 millimeters.
3 millimeters would be too close.
Too close.
What's the
Okay.
difference?
I
About a
maybe I'm-
centimeter and a half. Somewhere around a centimeter, yeah.
oh,
Somewhere
okay.
around a centimeter and a half above the level of the ankle joint.
Do you know what I'm thinking about though? Maybe not. Because I thought there was something that was like 3 centimeters with the ankle joint. You drop your arm like 30 degrees, and then maybe I'm just.
Or second one, that's okay.
Yeah, if it's your second screw, that's probably exactly it. So I guess it would just depend if you were talking about that initial screw, that second screw, and 30 degrees is exactly right, because that's where that fibula sits within that incisora.
Okay. Got it.
What do we see over along that medial side? I feel like I've used this x-ray before, so we might have talked about this before. Does it look normal?
No.
No, so what could that be? This is a post-op x-ray, right? So he's obviously post-op. I'm gonna tell you this is 2 days post-op. Would we have a hypertrophic non-union form 2 days post-op? Too soon. Would we have heterotopic ossification 2 days post-op? Too soon. Bone callus, too soon.
I can't tell if it's comminution or just like a chip fragment.
Okay, so are we gonna agree that it's bone?
It appears to be bone.
Yeah, what if we put it there? Right? Because I'm giving you the context and telling you this is only 2 days post-op. So you've got to take everything else off the table. Too early to look at any signs of healing or anything like that. So always appreciate in areas where we've got these severe fractures, especially areas of comminution, that we might then use some sort of augmentation to pack that area with bone that we need for it to consolidate or to heal. Good.
Dr. Pratt, while I appreciate and I understand that the syndesmotic issue could be affecting the ankle joint, couldn't it was brought up in the chat, couldn't it also be the deltoid as well? Insufficient fixation of it or damage to it?
So usually if you have a medial malfracture, if you have a medial malfracture, do you have a deltoid rupture and 90 whatever % of the chances?
So when you think of those fracture classifications, even remember how we always say medial mal or deltoid, right? Because
Correct.
it's typically one or the other that gives way. So the theory would be that if we had that complete medial mal avulsion, that it snapped off that medial mal, that the deltoid did that, and the deltoid then is still to some degree intact. So you've got the deltoid attached from that medial mal piece that broke off. So think of something giving way, either ligament or bone. And in this case, it was bone that gave way. Does that make sense?
Absolutely, but
So
wouldn't
we
there be any stretch to the deltoid?
I mean, I guess theoretically you could still have stretch to
Okay,
the
it's just
deltoid.
unlikely.
Yeah, it's more unlikely. If you're
Okay,
talking
thank you.
about soft tissue holding up the medial gutter there, what if, especially if you reduce this percutaneously and don't open it up, what soft tissue structure could slide in there that would make it irreducible?
Yep.
PT.
Yep, exactly. So, and they've published plenty of papers on PT interposition, especially when you're trying to close reduce these patients. If you've done a really good job with your closed reduction and it still just won't close reduce after 1 or 2 attempts, it may be such that PT is interposed. Excuse me, I'm gonna sneeze.
Thank you very much.
Okay, we've spent plenty of time on that one. Let's move on. Let's move on to another case. Somebody want to take this one? I'm gonna.
The youngest volunteer yet.
Yeah, we've got our youngest volunteer. Anybody want to take this one? I promise I won't ask as many questions on this one.
I'll take it.
Okay, go for it. Tell me what you see.
So
So describe the fixation.
we have a lateral plate with one syndesmotic screw.
Okay. So
Um,
is it fully threaded, partially threaded? Is it tricortical? Is it quadricortical?
it's fully threaded quadricortical.
Good.
And I think this was a SER fracture
Okay, so why would you say that?
because it looks like it's a lower fibular fracture, just
Okay.
slightly above the ankle joint.
Okay.
And I would say it's an SER 3.
Okay, so now obviously next steps, we're going to start off with SCR. So if we're going to say it's SCR, what's SCR1?
SER1 is a medial, AITFL. And then your fibular fracture, then your posterior mal.
So, oh, I'm sorry, I'm trying to draw on this. So we're going to start at the AITFL, just like you said, moving clockwise, right? So moving clockwise right around to step 2, which would be distal fibular fracture. Moving around the back of the ankle joint for 3, like you said, which would be syndesmotic disruption, posterior mal. Moving around then still over to the medial side for a 4, which would be deltoid or medial mal.
Yep.
So you said this was a what?
3.
Okay. Could it be a 4?
Doesn't look like the deltoids are disrupted too much and doesn't seem like there's a fracture line at the medial mal.
Good, good. So when you're looking at this, we know we've hit at least 3. Why?
A double density sign.
You got me. I don't even know what a double density sign you're
Extra-
talking about.
Yeah, I'm thinking maybe it's probably the wrong thing.
Yeah, somebody said it. Syndesmotic screw, right? So you see that syndesmotic screw there. So we knew that we hit the point of syndesmotic disruption here. So looking for a 4, if we're going to say, is this an SER 4 or not, you're exactly right. So we look for fracture of the medial mal. We don't really see one, at least in this AP and lat angle that we have here. And then we're looking for what as far as deltoid disruption? What do we look at? What's it called, the term? Yeah. Medial gutter, right? Or medial clear space. Yeah. People are keyboard heavy today. All right. So that's our analysis of an SCR. Anything else you wanted to talk about with this? I guess we can talk about the interfrag screws too.
Mm-hmm.
So you described the fact that we had that distal fibular plate on here, 1/3 tubular plate. You described the syndesmotic screw, the singular syndesmotic screw. Does it look like it's at an appropriate height, an appropriate level?
Yeah.
Yeah.
To me, it does.
Yeah, looks like an appropriate level. Do you think they got adequate syndesmotic reduction?
Yep.
Yeah, why is that?
It looks like there's no gapping or diastasis between the tibia and fibula at where the syndesmotic screw is placed.
Good. So if somebody's asking you to critique, was the syndesmosis appropriately reduced? You're going to look at things like and comment on things like tib-fib overlap. You're going to comment on the fact that the talus is sitting well under the distal tibial plafond. So the alignment of the tibio-talar joint is rectus. It's not in any retained varus or valgus. One thing you didn't mention were those interfrag screws, right? So important to mention that we have 2 interfragmentary screws going from which direction?
Looks like anterior to posterior.
Yeah. So take a peek. Yeah, look at that lateral. That lateral will give you a good indication. So going from anterior to posterior, just A to P. Okay. Anything else on this one?
Yes.
Let's move on to another one.
Click off.
Oh, this is just a discussion slide.
So this is just an example of how to differentiate between the 2 Weber B type fractures. So which are those 2?
Sorry,
Oh,
I gotta
let me
take
go
my,
back.
sorry, I gotta get my annotation off of there.
Pronation, abduction, and SER.
Good. And which one of these 2 has the lateral spike if you're looking on an AP?
Pronation, abduction.
Good. And then SCR has, where is the spike oriented?
Posterior.
Good. So if you're looking at these 2, which one of these 2 could you actually put your interfrag screws through the lateral plate?
Well, since it was done on the last one, I would say the SER.
Yeah, so that's, where's the mouse?
So if you're going to put lag screws through a plate, then it needs to be across. Hold on, we're getting our drawing back here. Mouse goes away when we use this.
I just want to go back. Yeah, so that's, I guess, probably one of the points I should have brought up just a second ago, is that can give you a real quick and easy indication that this is SER, right? Because we have external compression screws to the plate. So those interfrag screws exist outside of that distal fibular plate. So that means that that spike on that distal fibular fracture was posterior, right?
Posterior.
Because we want our interfrag screws ideally as close to 90 as we can get to the direction of that fracture fragment.
So if you look on the left, these lines are just showing the direction of the forces, and the bottom left photo shows the external force, which is starting in the fibula and exiting the posterior fibula, which is why we get that posterior spike, compared to the top left one going straight across, which is why you get the lateral spike. But depending on what literature you read, I just want to address this because there may be some confusion. In most podiatric literature, a pronation abduction is a Weber B ankle fracture. But this is a little chart from the George Guman trauma book. I don't know if anybody uses that anymore. But occasionally you can have this fracture be transverse or above the level of syndesmosis. And if you look at like ortho bullets, for example, or some other orthopedic resources, they may refer to a pronation abduction as a Danis-Weber C. So that is out there just in case somebody questions you on it, but most of our literature says it's a Danis-Weber B. So what type of ankle fracture do you think this one is?
Knowing that we just talked about those last two classifications.
Pronation abduction.
Pronation abduction.
Yeah, good.
Good.
So just to see the difference here between interfrag screws that exist within a plate because they're going from lateral to medial versus interfrag screws that exist external to the plate because they're going from A to P. How about this one?
SER.
Okay. SER what? Now's the time to get specific, right? Yep, good. SER4. How about this one? I'll tell you that the patient is 13. No. Yeah. Yeah, nice, guys. So patient's 13, so it's peds, right? So it's a juvenile to low fracture. So why does that to low fracture happen? Why do we see that type of a fracture pattern? What's the order of closure of the distal tibia? Good, Orlando got it. Central, then medial, then lateral, right? So the only one left open at a certain point in time is the lateral. So that's the reason that we can see these juvenile to low fractures. Good. How about this one? Someone take this one for me and describe what you see. Not via keyboard.
I can read it.
Okay.
Looking at what looks like an AP ankle, significantly noting at the medial malleolus, looks like a vertical fracture through the medial malleolus that's slightly displaced. Joint space looks congruent. No, I don't really see any lateral shifting of the talus mortis with the tibia. Clear space looks intact.
Good. Orlando, that's a great read. The only thing I would add to that is be a little bit more specific when you talk about displacement. So knowing that 2 ± 2 millimeters is kind of our golden rule in a lot of cases for determination of ORAF, talk about whether it's more or less than that. So that can be helpful when you're describing these x-rays to someone that, you know, this is a vertical medial malleolar fracture with displacement over 2 millimeters. So what kind of Log-Hansen classification typically gives you a vertical medial mal fracture?
Usually a supination adduction, type 2.
Good, good. What do you think is the one thing in these types of injuries that you really want to evaluate or be wary of post-operatively or post-traumatically? So thinking about that fracture pattern, specifically along that medial side.
You're thinking more of like an OCD possibly of that?
Yeah, exactly. Exactly. From that distal tibia knocking right into that medial shoulder. So you're really wary in these SAD patterns of getting an OLT or an OCD along that medial shoulder. Good. And obviously, yes, also as Aaron said, PTOA, post-traumatic arthritis, as with any of these ankle fractures. So remember to look for those OCDs in SAD.
If you don't see an OCD, would it still warrant advanced imaging to see if there was one you couldn't see?
You'll see an intraoperative.
Yeah, I mean, I guess, you know, for somebody like this, like Rosante just said, you're going to take them to the OR. So you would be able to actually physically take a look at that. But if we are going to decide, you know what, let's get advanced imaging anyways and just double check. Sam posed a good question. Do you want CT or MRI to assess for an OLT or an OCD? Can you get
an MRI to confirm?
Can you do both? You can do both. What would be one advantage to, one or the other?
CT would help with surgical planning, but MRI would see smaller OCDs and also subchondral.
What might an MRI overestimate, though? Or I asked that in a horrible way. I just sort of gave the answer. I just sort of gave the answer as I asked the question. So why might I'm trying to read the comments at the same time. I absolutely agree with you in the sense of you're probably going to get a CT anyways for surgical planning. So would you also get the MRI in addition? Probably not. Your CT is good in that sense. But why might, I should have posed it a totally different way. Why might an MRI overestimate the size of an OCD? Okay. Inflammation, marrow edema, right? Yes, exactly. Good.
I want to bring up something too about the decision between CTs and MRIs when you have a patient who's in the emergency department. Which one do you think is a lot more accessible and quicker for a patient to have done?
CT.
Yeah, that's
good.
A good point.
So a lot of times MRIs take a while to have done, and a CT scan is very quick, and it's usually right near the emergency department radiology anyway. So we get those routinely in the ED.
Good.
Can anybody explain, so this is from the AO book, can anybody explain why you'd consider using this type of fixation for a vertical medial malfracture and how it actually works?
What type of plate do you think that is?
Buttress plating?
So why is it acting as a buttress plate? We'll talk about plating later on if we have some time. So what's the point of a buttress plate do? So think of that distal aspect of the plate, and I have a picture of this later on, almost like a thumb buttressing or holding on that distal fracture fragment, right? So screws go into the main part, the main piece of bone, and then that fragment of bone is being held on by your thumb or by that tip of that plate. So yes, it's acting as a buttress plate. Let's keep moving. We got a bunch of these here, so we can get through at least a couple more of these. Anybody want to take this one? No? You guys want to be done?
I can read this one.
All right. What do you see?
Okay. So on the image on the left, looks like we have a long leg AP view of the tib fib.
Good.
Working distal, noticeably I can see the distal tip of the fibula. I don't know if that looks possibly like a potential avulsion fracture of the tip of the fibula.
Okay.
I see some translucency at that distal end of the fibula. Working more medial, doesn't look like a fracture is there, but I do see some widening of that medial clear space.
Definitely, right?
Yes.
So what would be considered widening if we're going to talk about millimeters?
Something greater than 4 millimeters, I think.
Oh, shoot. I'm just ruining trivia tonight and giving anyone who's listening a heads up. You said how many millimeters, Orlando?
Greater than 4 millimeters.
Okay.
Was that what you were looking for, or was there a better answer?
A little bit more than that, typically.
So like 6?
Yeah.
Was it?
Yeah.
Okay, 6 millimeters.
Good. Okay. So definitely agree with you on the widening of the medial clear space there. Look over at the lateral. What do you see on the lateral?
lateral, I see what sticks out most is what looks like a possible avulsion fracture or Volkmann fracture of that posterior mal of the tibia.
Yeah, good. So what if you're ever concerned and you're like, you know what, I can't tell. I can't tell if that's a true posterior mal fracture, or is that just overlap of some sort that I'm seeing from tib-fib? What would you do?
Just ask for another image.
Yeah, ask for another image, get a CT. CT would be a great option if you have that availability. So you're seeing widening of the medial clear space, so you have some insufficiency of the deltoid. We can check that off. We've got posterior malleolar fracture here. So what are you starting to think as far as potential fracture patterns?
I mean, this could be potentially still like a PER. Would it
Okay.
be crazy to ask for an even more proximal view to see if like there's a possible Mason move of the fibula?
It would not be crazy in the least. That is absolutely correct. So tell me what you see.
Basically see that oblique fracture of the fibular neck.
Yeah, exactly. So you
consistent with
already
the
answered
Mason
my next question of where does the Mason fracture occur? Good. Good. So if we're thinking, is there another slide for this one or no? No. So if we're thinking about fixation in this case, what are you thinking?
You could probably just maybe approach it with like a syndesmotic fixation, again with like a plate with some syndesmotic screws, maybe a tightrope for the syndesmosis.
Good.
In terms for the posterior fragment, I know there's that rule, if it's like greater than 25% of the joint surface, you can attack it.
Yeah, at posterior mal, and that's exactly something to sort of have in your wheelhouse to be able to talk about as it relates to posterior malleolar fractures. You'll find some people that say, no, just forget about that percentage. Always follow that sort of plus or minus 2 millimeters of displacement rule. If it's more than 2 millimeters displaced, fix it. So you'll find people that tend to fix these all the time, and those may be fixed from P to A, those may be fixed from A to P. But you'll find people that abide more by that than they do the percentage rule. And some people will say, nope, unless it's right around that 25-30% mark of the distal tibial plafond, that's when I vary whether I fixate that or not.
What do you think would be one advantage to fixing all the posterior mal fractures you see?
Can you definitely, you can just restore like that posterior ligament attachment of the mortise?
Yeah, we're seeing in a lot more literature published recently that if you actually recreate the incisura, the fibular incisura, where it's supposed to be, then you get a better reduction of the fibula into it, as opposed to allowing the fibula to slide more posteriorly if you don't fix the posterior mal. So some people will just fix that just to give the extra stability of the fibula in the incisura.
I do have two questions real quick.
Yep.
So, I mean, I think we've been taught that for the Mason move, obviously, you probably wouldn't touch that with its one that's out of our scope, and it's so close to the common peroneal nerve, so normally not even orthopedic would touch it. Is that still pretty common?
Yeah, you're not going to put a plate up there.
Okay. And then going back to what I thought I saw as that distal transverse lucency at the fibula, is that consistent with the fracture, or am I just misreading that?
That's a trick. That's actually, what accessory bone would we see down there? Just use yeah, there we go. Os subfibulary. That's all it was. It's not actually an avulsion fracture down there.
Okay, thank you.
I know we don't have much time left. I want to move on. There's some slides. Oh, let's go back to this one. Who remembers this? Someone remembers this, I'm sure. I'm going to go back to the fact that this is a sneaky, that this is a PEDS patient, right? Don't ever let somebody trick you when they give you x-rays and you're looking at growth plates and not fractures. Yeah, so somebody already commented on that. So that pediatric triplane fracture, where it looks like what on an AP versus what on a lateral. So a Salter-Harris. So so if we're looking at an AP, it goes low, right, below the epiphysis. So that would be Salter-Harris 3. And then on the lateral, it stays A for above the level of the epiphysis, up and out the metaphysis, and leaves that metaphyseal spike, aka the what's the name of that? Yeah, the Thurston-Holland sign with that metaphyseal fragment. And that can sometimes be minuscule and real tiny, or sometimes that's a huge metaphyseal piece. But a Salter-Harris type 2 on a lateral. But we know that this would be best regarded as a Salter-Harris type 4. Good. Where is complication? What's that called? Distal syndesmosis. That is called, buzzword.
Heterotopic ossification.
Yeah, why does that happen? I already gave it away by saying syndesmosis, right? So a neglected syndesmotic injury. So we failed to address the syndesmosis. Yeah, movement. We end up seeing down the road that heterotopic ossification. What do you think happened here? I just wanted to go over a couple of these complication slides. Those are all reasonable suggestions, though. What else? Anybody see anything else that maybe didn't get addressed the right way? Nobody's wrong yet for what you've described in the comments. Oh, yeah. Good. So do we still see that posterior malleolar piece? Look at that lateral.
Still in the right position.
Still in the right position. Rest of the extremity is not, but that posterior malleolar piece maintained itself. So that did not get fixed appropriately. What about this one? What's this look like? Right on that disaster. Dr. Clardy said disaster.
My
The talus displaced anteriorly. Yeah, so you guys are giving us a lot of stuff in the comments. Give me one word that might describe the condition of this ankle. Think bigger picture here. You're not wrong as far as not enough fixation. Talar neck fracture. Yeah, there we go. Charcot, right?
Yeah,
This is.
Natalie
Yeah, I see.
Oh, a while ago.
Oh, she did?
Yeah.
I didn't see that. I'm sorry.
And now 9 people.
Yeah, so post-traumatic Charcot, right? Sorry, Natalie, I did not see if you answered Charcot for this one. What about this one? Did he give me all of? Is it yours?
No, I don't think this one is.
What's the issue here? Ankle joint, normal or abnormal? Totally abnormal, right? We talked about syndesmotic screw placement earlier. What do you think about where those syndesmotic screws are at? Definitely too close to the joint. I agree with you. Look at that distal syndesmotic screw. It's basically within what should still be an ankle joint and is likely no longer because of such severe PTOA. So was another question I missed.
Yeah, from 2 people down.
Oh, is the plate fixated to the fibula properly? Is it? Why or why not? Why would it not be fixated to the fibula properly? What would be the issue? Sorry, I'm trying to.
So let's answer this question about, do they always need to be quad cortical? Has anybody else, or has anybody out there done like a lit review on syndesmotic screws? I'm gonna take that silence as a no. If you actually, thank you, at least somebody. There's actually no right answer to whether they have to be tricortical, quad cortical, one of them, 2 of them. If you do a lit review or even a Cochrane review, there's nothing that says you have to do anything. We just don't want to make them too high because there's an artery up there. Anybody know what artery you could hit?
Perforating peroneal.
Good. Yeah, we don't want to hit that, and we don't want to be too low, like Dr. Pratt said here, and be in the joint. What do you think happened when they were fixating the ankle fracture? Look at the position on the lateral. What was ignored during overall fixation?
Did they like not restore it to the where it needs to be lined up on the talus? It's like too posteriorly
Yeah,
displaced.
It doesn't look like actual alignment of the ankle joint was identified during the ORIF, because the fibula is very posterior. Whether or not it's a cavus foot, we have a very what pathology is going on in the anterior ankle that was contributed from the initial ORIF.
Yeah, those osteophytic changes at the talus and the into the tibia.
Yeah, what diagnosis could you call that? What if we said this lateral view is a weight-bearing view?
Osseous equinus.
Yeah, osseous equinus, good. So you still, just like we talked about with ankle fusions, when you want the ankle to be rectus, when you do an ankle ORIF, you still want the ankle to be rectus when you're done. Otherwise, you're going to cause long-term pathology.
Good. All right, we've already hit 1 o'clock. I'm going to skip through the rest of this to get us to our important slide of the presentation here. All right. So we have had the pleasure of having 4 excellent 4th years with us throughout the month, and they've got a poster to present.
Unmute my. All right. Hey guys. So we did we did research with Rosante, Pratt, and Cloudery, and we did this case review of the use of a minimally invasive plate osteosynthesis in an arthroscopic ankle arthrodesis. So the purpose of the study was to show that the use of using a minimally invasive arthroscopic ankle arthrodesis technique to apply an anterior plate with 2 compressive screws to osteoarthritis of the ankle. So we all know that osteoarthritis of the ankle is very painful. It's limiting pathology. As it gets worse, you have limited conservative treatment, and a common option for surgery is to do either a TAR or more commonly an ankle arthrodesis. So the ankle arthrodesis, there's so many approaches you can take, but the issue is when you go in, you have a high rate you can have a higher rate of non-union, or you can have a high rate of union. It depends on the approach. So it offers a shorter post-op visit and it's less costly. However, wait, sorry. Oh, sorry, I've got this mixed up. So arthroscopic, we like to use that for the high rate of union. It's smaller holes. The only issue is you don't get to see the ankle joint as well as if you open it. Now, opening it, that's the traditional stance on surgery. And you can kind of size everything better and you get a better view of what you're doing. But with this, it's a bigger incision. You have a higher likelihood of having dehiscence, and you can have a higher chance of non-union because you don't have as good of blood supply. So in this, what we had is we had a 69-year-old non-diabetic female patient who had an injury about 35 years ago, and she had to have open reduction with internal fixation. So she's been having pain for the last 10 years. It's getting worse and worse, and she can't do her daily activities. So we tried it over the counter, it failed, didn't work. So then we decided to do an ankle arthrodesis. And so the way they did this is they placed her on a supine operating table, thigh tourniquet. So we did the standard anterior medial, anterior lateral ports for the arthroscopy, did joint preparation with osteotomes, bearing curettes, and fenestration. And so then what they did is they took a lateral plate, they molded it and placed it on with a bone graft, and they fixated it with screw fixation. And then she was kept non-weight bearing for the first week. And then she was placed into a walking boot, and she was allowed to slowly put weight on it with a walker for 12 weeks post-op. And then at the last presentation, she had no pain. She was allowed to transition to regular shoes. And then at 5 months, she was able to walk in regular shoes with no pain, no brace, alignment was well maintained, clinically and radiographically with no motion. So the figures on the very far left, those were her post-op. Then we have our intra-op and then our post-op. Okay, so discussion. The use of an anterior plane ankle arthrodesis has been found to show optimal clinical results. There's very high fusion rates, as high as 90% in many cases. And it's even beneficial in patients who are high risk, such as diabetics. So another reason why you might have high union rates is the increased stability of the construct. So many biomechanical studies have showed that with partially threaded screws, you can increase the construct stiffness by 3.5 times in the sagittal plane. So the anterior plate fixation is ideal in patients with multiple risk factors for non-union. It can create this tension band construct that'll convert distraction forces at the ankle into compression via the ankle plantar flexors. So ankle arthrodesis is a big surgeon preference, but many patients prefer arthroplasty because they have a decreased VAS pain score compared to arthrodesis that's open. And there's a lot of pain relief with the use of this technique. And there's shorter time to fusion because you have this minimal soft tissue stripping that's performed during the procedure, and it's a low morbidity that eliminates knee hospitalization in most cases. And with arthroscopy, the average time to union is 9 weeks and just less painful compared to the open. And that was the research we did. Any questions? Good.
All right, so that class is dismissed. So our next event obviously is going to be tonight, which is our trivia night. So at 8 p.m. Eastern Standard Time, we will be kicking off our trivia night. As an announcement of what to do, so every team, I heard that there's some teams being formed and stuff, which is great, but one person needs to have a phone to answer, and everyone needs some kind of laptop or desktop to watch the questions. So all the questions will be on your screen, computer or TV screen, whatever, via Zoom. And then on your phone, either download the app of Kahoot, not Kaboom, sorry, Kahoot. So either the
You
app,
can download Kaboom.
you
I just,
can get
I just
Kaboom,
don't know
but
what that
it's
is.
not going to do anything for you. So download the app for Kahoot or on your phone. But when you get into the Zoom, there will be a code on the first screen as everyone's entering into the Zoom meeting. And you just put that code into the Kahoot, and then we'll go from there. So we're all looking forward to it. Obviously, we have a couple different prizes for first, second, and third place. And everyone, first place, it's going to be, first place gets their pick of what they want. Second place, second pick. Third place gets the crappy third place. I'm just kidding. It'll be a lot of fun. And all those things will be announced tonight. So looking forward to participation and all that stuff. And it should be fun. There'll be 3 rounds of questions and all that stuff. So we'll explain all that tonight. So make sure to tune in for that. And then I'm going to put all the details on our Instagram account too, just in case you nodded off there for a second.
All right. Have a good afternoon.